Hello, good morning. This is Shantan. This morning we are presenting on surgical management of benign prostatic hyperplasia. I've worked on this with Stephen and JT. Today we're going to go over the pre-operation considerations. We're going to talk about what benign prostatic hyperplasia is, talk about the testing, medical treatments, and then we're going to obviously dive into the AUA guidelines on the surgical management. There's a number of different procedures that we're going to go through and we're going to talk about. We're going to discuss the pros and cons of each, what they can be used for, and as you discuss these with your patients, which ones you might be pointing them in the direction of talking about with the urologist. Let's dive right in. Etiology. Well, what is it? It is defined as a proliferation of smooth muscle and epithelial cells in the prostatic transition zone. This picture shows the arrow diving down in through the prostate. That is the area that we are concerned about. When the prostate enlarges, it can cause problems. It can obstruct urine flow. It can obstruct emptying of the bladder, and you'll see problems with that. The etiology is unknown, but we do know that testosterone and DHT do play a role. Prevalence, it's pretty prevalent in the older male population, 60% at 60 years old, 80% at 80 years old. The severity really depends on the size of the prostate. If you have enlargement, it can be worsened over 80 cubic centimeters. The complications, including the LUTS, the lower urinary tract symptoms, can be storage of urine, voiding, post-void dribbling. In general, you can have other problems such as bladder stones, detrusor muscle weakness. In general, though, you are referring to the symptoms of benign prostatic hyperplasia. The symptoms for BPH are going to be very similar to prostatic cancer. So in the medical treatments, first things we're going to try are alpha blockers. Alpha-1 selective blockers, specifically tamsulosin, terazosin. This reduces the smooth muscle tension in the urethra, the bladder neck, and the prostate. And this can go a long way in helping you reduce or avoid surgical therapy. 5-alpha reductase inhibitors or 5-alpha blockers, finasteride, are also recommended to prevent progression of LUTS, reducing the risk of surgery. This is a treatment that requires over 6 months of use. Often, both alpha blockers and 5-alpha blockers are used in combination for more rapid effects and more long-term effects. PDE5 inhibitors, sildenafil, can often be combined with an alpha blocker. You definitely want to use an alpha blocker first, but the PDE5 inhibitors are going to be good for your patients with BPH as well as erectile dysfunction. Anticholinergics can be used, but it's mainly recommended if the primary LUTS symptoms are irritation and if the post-void residual volume isn't elevated. And we'll talk about that just a little bit in this testing. Pre-surgery, you're going to need some tests to know exactly what's going on, and this is stuff that you can do in primary care as well. We're going to obviously want the medical history. We need a physical exam, including a digital exam, to feel the size of that prostate. There is a AUA, the American Urologic Association Symptom Index, and there's a list there that we want to evaluate where they are as far as their LUTS symptoms. We also want to do a urinalysis to screen for PSA, for prostate cancer. Number of measurements that we can do: post-void residual urine measurement. It's exactly how it sounds. After voiding, what is the residual urine measurement in the bladder? Uroflowmetry is where they urinate into a special funnel that is connected to a measuring instrument that collects the urine, how much flow there is per second, the length of time until the completion of the void, presents a graph very similar to this, which can be interpreted by the doctor. Pressure flow studies is a mammometer that is inserted into the bladder to check bladder pressure and flow rate. All of these things, as well as imaging, you're going to use ultrasound, cystoscopy. You can use an MRI or CT, as the image here on the right shows. These are all going to be things that you need to know before you go into surgery, but certainly as you are looking at the medical management of BPH. The last note here, treatment failure is very important, as we know, with all of our patients to inform them of any of the downsides and the potential risks of any of the treatments that we take, especially with surgery. This is extremely important that they know all of the problems that might be associated with surgery. Indications for surgery: renal insufficiency, refractory urinary retention, recurrent UTIs, bladder stones, hematuria, and then obviously the LUTS from BPH that isn't responding to any other treatments. And if it is causing significant distress, that's obviously something your patient is going to be wanting to talk about. And you can refer to urology at that point, but you can also discuss with them about the indications of surgery. So now we're going to go through what the individual procedures are. Hopefully the videos here work pretty well. Okay, so the first treatment that we have is a transurethral resection of the prostate. This is considered the gold standard for many decades, has been used for a long time. It's indicated for medium-sized prostates. That would be 30 to 80 cc's. This is often the first approach for those medium-sized prostates that haven't responded to medications. However, because of a certain thing called TUR syndrome, transurethral resection syndrome, we are looking at other newer treatments, which we're going to go on to talk about. TUR syndrome, obviously with this scope, you are running a fluid through the scope into the bladder, and that can present risks of changing fluid balances, electrolyte balances in the body. This particular video is showing an example of a bipolar resection. You can also have monopolar, but bipolar does have some improvement due to being able to use a isotonic fluid instead of with a monopolar, you are unable to use an isotonic fluid. And that can cause myelinolysis, central pontine myelinolysis, and that's something that's a major concern with TURP, which is why we are looking at other treatments. Other risks that you may have is bleeding. You can also have loss of erectile function, and you can also have what's called retrograde ejaculation, where the semen, the sperm that is released, does not travel out the urethra. It comes up backwards into the bladder. And if this is a younger patient, that might be a concern. Typically with prostate hyperplasia, you're going to be looking at this in older males. So not usually a concern, but something to discuss with your patient. It definitely can play an impact on their sexual function. So just to recap, there is monopolar, bipolar, really depends on the surgeon's preference, but the bipolar is kind of the way to go because you have a reduced risk of clot retention, bleeding, less time with a catheter, less time hospitalized, but it really just depends on physician experience. Here's all of it. The next treatment, let's see if I can jump ahead here. Yes. This is just going to show another video. Let's skip that. The next video is of a simple prostatectomy, and this is exactly what it sounds like. You are going in through the abdominal wall and cutting the top of the bladder, and then moving your way down through the bladder neck to resect that prostate. This is done often for prostate cancer. Radical prostatectomies are typically going to be done with this approach. Considered for large prostates with BPH. The clinician has a number of options, robotic, open, laparoscopic, and this has really been the gold standard for those larger prostates. It's really easy to remove all that tissue through this way, and the outcomes are relatively good. However, you do have a risk of retrograde ejaculation because you are stretching that bladder neck as you go in for the surgery. As you stretch it, you have issues also of bladder neck contracture, which is essentially scarring and fibrosis of the bladder neck that eliminates the vast improvement that you may get from simply removing the prostate. You may also see incontinence rates because you have stretched out that bladder neck, so that is something to consider. With this, you have an average of 5-day catheterization and hospitalization. Up to 10 days has been noted. We go through the rest of the treatments. They are typically used by preference with the urologist and with the patient. There's a variety of different treatments that can be used. And we'll have an algorithm at the end that kind of helps you look through which treatments you might use. Transurethral incision of the prostate is exactly what it sounds like. You're making an incision through the prostate. This is mainly used for patients with those smaller prostates, not quite as large, because you're simply making an incision. If there's that much tissue there, it's not going to give that much of an improvement. The reason you would do this is because there is a slightly lower risk of erectile dysfunction and also lower rates of retrograde ejaculation and blood transfusion, although the studies seem to have shown that these are insignificant differences. This is all based on the guidelines. This can be recommended and can be used if the patient so desires. The next treatments we're going to talk about: transurethral vaporization of the prostate and photoselective vaporization of the prostate. These will be used for your medium or smaller prostates. Main reasons for using this are less bleeding, shorter catheterization time, and shorter hospital stays, especially compared to the TURPs, kind of the gold standard that everything is compared to. This can be recommended essentially vaporized with a laser while also coagulating the blood vessels. So there's basically no blood with this at all, no blood loss at all. You don't need morcellation, which is basically blending of the tissues to remove them. However, the risk factors are still quite high for retrograde ejaculation, 84%, erectile dysfunction, 12%, and much lower rates for incontinence and urethral stricture. Next is prostatic urethral lift. This is a very good for medium prostate sizes. And there we go. Let the video go here. If it's less than 80 grams and there's no obstructed middle lobe, this is an excellent treatment. You essentially use the scope, go into the prostate, and there are transprostatic suture implants, essentially a T-shaped bar that goes through the prostate into the prostatic capsule that has a spring that pulls on the prostate and compresses the tissue. This will expand the urethral size. As you can see here, when he goes in, it's almost like a staple. You're injecting this T-shaped bar that lifts the tissue, expanding the urethral cavity. This is a quick treatment, and it is pretty good because it preserves sexual function, but it's not as effective as alleviating lower urinary tract symptoms. You will see calcification when you have that metal in there. You're going to see calcification. You may see the tissue expand past the tissue. So can be helpful, not necessarily, but definitely improvement in sexual dysfunction, as we'll see in this next slide. It should definitely be considered for your younger patients who want to preserve erectile function and to prevent retrograde ejaculation. Much better outcomes compared to TURPs and some of the other treatments as well. Next, we have transurethral microwave therapy. This is another simple, somewhat less common treatment that is used. Essentially, the microwave is inserted with the scope, and the tissue is heated up, and that's supposed to kill the prostate tissue, which retracts the prostate tissue. You can use a rectal thermometer to monitor the surrounding temperature to make sure that you're specifically aimed at the prostate tissue. However, the outcomes, although obviously improving BPH, you may have a longer catheterization time, which implies longer healing time, and you also have a higher retreatment rate than TURPs, meaning it may not be as effective, but water vapor therapy here. Jump through this thing again. This is where you are using hot steam, similar to the last one, except hot steam is what kills the prostate tissue. This is again for medium or smaller, very good for preserving erectile function and ejaculatory function. However, with comparison to other treatments, you may see increased dysuria, hematuria, frequency and urgency may be increased, urinary tract infections also increased. So something to consider with this treatment. Transurethral needle ablation, somewhat similar to the last treatment. You're using a needle instead. This one is not recommended. The reduction is far less than initially was expected because essentially the BPH is replaced with a scar. So not recommended. You may hear patients ask you about this, but this is not something that is currently done and is currently not recommended. Laser enucleation, as we stated earlier, similar to the vaporization, used for medium or larger in this case. A scope and laser are inserted into the urethra. The laser cuts away the prostate tissue. Depending on which kind of laser you use, the holmium laser can cut 4 millimeters deep. The thulium laser, just like this one is, can cut 0.2 and 0.4 millimeters deep. So very, very good treatment for your larger prostates, and obviously with the instant cauterization, you will see less bleeding. Aquablation is another treatment that can be recommended for your smaller prostates as well, your medium-sized prostates. Essentially, you are using high-force water to remove that tissue. The idea was that this would be a minimally invasive procedure. However, it still requires general anesthesia, so it isn't considered minimally invasive. There is a lower risk of retrograde ejaculation, but there is also a lower volume reduction, so something to consider. Lastly is one that is also not really recommended, using a catheter, releasing these beads into the arteries of the prostate to impede blood flow, kill the prostate, and to reduce the size of the prostate that way. Not recommended. This is done by the interventional radiologist. The benefits aren't clear, so the FDA really has only approved this for prostatic bleeding, not for BPH. We can skip the video here. Here's an algorithm that is pretty helpful, pretty useful. Again, it really depends on your prostate size. Large prostate, average prostate, small prostate. The smaller your prostate, the more options that you have. Your larger prostates are really limited to your prostatectomies and your laser enucleations. As you get smaller, it really depends on what sexual function you're trying to preserve, risk of bleeding, hospitalization time, and those kinds of things. Those are things that you're going to be discussing with your patients as you're deciding through the various options. Size independent options here, specific to medically complicated patients if you have somebody that is on an anticoagulation, antiplatelet, or somebody that has a bleeding disorder and are at higher risk of bleeding. You're going to want to consider either the vaporization or the lasers, as this essentially provides instant cauterization and reduces the amount of blood loss. That's it. That's all the procedures. There are quite a few to choose from. Again, discussing what your patient is hoping for, discussing with the urologist what he's comfortable with, he or she is comfortable with, and just ensuring that the patient really can maintain any of the outcomes that they're looking for with the lowest risk of the things that they want to avoid is really what we're going for here. Thank you for your attention. If you have any questions, go ahead and send us an email since we're not here to take your questions here. And these are our references. There is a bunch of them. Thank you again for your attention and have a great day.